The placebo effect is everywhere, but some things amplify it, and knowing how to spot them can keep the treatment on the right path. Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue.
I've been in practice for 25 years, and for most of that time, I've made it a habit to rate symptoms at every visit. That means years of ratings and thousands of patients. And today I'm going to share two patterns I've seen that can help you separate the real medication effects from the placebo effect a little better.
The placebo effect is not evenly distributed. Some disorders are more responsive to it than others. Last year, Tom Bashore and colleagues from Germany ranked the placebo effect for each major psychiatric disorder. At the top, a major depression and generalized anxiety, with an effect size of 1.2 to 1.4. That's larger than the effect of Adderall in ADHD. By comparison, the effect size for antidepressants is small, around 0.3. That placebo effect is even higher for children and for mild depression, but it falls a bit lower in treatment-resistant depression. Next come diagnoses in the middle, where the placebo effect is still large, around 0.7 to 0.9. Those are panic disorder, ADHD, PTSD, social anxiety, and mania. Yep, mania. Most mania trials are done in the hospital, where a structured environment and a few PRN lorazepams quickly stabilizes the symptoms. At the bottom are OCD and schizophrenia. But for these, the placebo has a medium effect size around 0.6.
When this paper came out, some people said, "What am I going to do with this? I don't prescribe a placebo." Ah, but you do. We all prescribe it. It is baked into every med we give, and includes not just the patient's hopeful expectations, but the natural course of the illness. The question is not, is my patient having a placebo effect, which is impossible to answer, but how much of a placebo effect are they having? And that's still hard, but a little easier to estimate. Dr. Bashore's study helps us estimate that by each disorder. Now let's look at two other factors you'll need to know about to assess treatment response.
And that brings us to our first clinical pearl. The placebo effect is bigger at the first visit.
I don't have proof of this one, but it's something I've seen in thousands of mood charts. Patients tended to report the biggest improvement after their first visit, regardless of which medication was started. Sometimes they'd come off that first visit medication and then restart it later, but their second response was not as impressive as the first one. So what is going on here? While I don't have proof, it is consistent with a lot of psychotherapy studies that show most improvements are made in the first few visits, and it's consistent with what we know about placebo. Yes, patients bring a lot of hope and expectations to their first visit, especially if they put a lot of thought into choosing that provider. But that's not the only reason. There's also regression to the mean.
Regression toward the mean. It sounds like a primitive defense mechanism, but it's really a statistical concept discovered by the early geneticist Francis Galton. When Galton was studying the heritability of height, he noticed that parents who were really tall or really short tended to have children closer to the middle. They regress toward the mean. In psychiatric practice, it means that we all go through highs and lows, triumphs and crises through life. These peak experiences are, by definition, rare. You can't reach an all-time low every day of your life, and random flux is a part of the slings and arrows of outrageous fortune. So translating this into practice, patients are most likely to start treatment when they are at a historic low, and chances are they are likely to move closer to an average low by the next visit.
So it's saying that we all move toward the average, which is what the mean means. In his book, The Mind Has Mountains, psychiatrist Paul McHugh talks about how he used regression toward the mean to counsel patients. McHugh was the chair at Johns Hopkins. so he saw a different kind of patient than the rest of us, as this story will show. Highly accomplished parents would consult Dr. McHugh because their child was not as talented or intelligent as they were, and they wanted to know what was wrong. McHugh would counsel these parents on Galton's law of regression toward the mean, that if your IQ is unusually high, chances are your child's will be several degrees lower. I'm not sure if the parents are reassured by this. Maybe you're scratching your own head about it. I mean, wouldn't you expect Einstein's children to be highly intelligent? Regression to the mean only applies to random events, so the kind of scatter among the bell curve is what we're talking about. This is not easy for us to wrap our minds around because our minds try to see the world as controllable and purposeful. Your child's IQ and your patient's mood are not entirely driven by chance, but we gotta admit, chance plays a bigger role than we give it. Bringing this back to practice, patients are likely to get better on their first visit by chance alone, by regression to the mean, even if I don't inspire a lot of placebo-laden hope when they meet me, and even if I prescribe the wrong medication.
Dr. Aiken, you may not have proof of this first visit idea, but you're in good company with this idea. I found a nice article by Daniel Zygmunt and Pierre Bleur called A Framework to Avoid Irrational Polypharmacy in Psychiatry. Love the title. Here's what they say. Clinicians should routinely consider tapering any extra medications that were added during times of crisis for additional symptomatic control. It is always possible that a patient improved due to placebo effects, regression to the mean, or the natural history of their illness, rather than the specific benefits of the medication. Then it goes on to say, cite studies where patients with stable chronic schizophrenia were successfully tapered off antidepressants and mood stabilizers. Stuff that, isn't really evidence-based for schizophrenia. And most were tapered off antipsychotic polypharmacy down to just one antipsychotic without any worsening.
Wow, that paper was from 2012. I didn't know they had that evidence of polypharmacy and schizophrenia back then, but we did just review at the Carlat report a pretty convincing study of antipsychotic polypharmacy and schizophrenia. These were patients in a long-term hospital unit, and they were randomized to either taper down to monotherapy or stay on their complex regimen with multiple antipsychotics. Not only was there no worsening, but their schizophrenia symptoms actually improved when they whittled it down to just one antipsychotic.
The bottom line, watch for exaggerated placebo effects if you start a medication at the first visit or in a time of crisis. Those are times when patients are likely to improve on their own, either by the power of hope or regression toward the mean. Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. What is the name of the phenomenon where an extreme random variable tends to be followed by one that is closer to the mean of the sample? A. Sampling error. B. Mean inference. C. Galton's inference. D. Regression toward the mean.
We'll conclude this podcast next week with another hidden placebo effect, but let's end with the research update. Last month, 2 studies found alarming trends in recreational psilocybin and ketamine use. In the first one, Joseph Palomar at NYU found a 37% increase in recreational ketamine use between 2017 and 2024 after interviewing over 3,000 adults at New York City nightclubs over that same time span. In 2024, nearly 1 in 4 nightclub attendees had used ketamine recreationally. Ketamine use rose most among women, adults over age 25, the college-educated, and people who identify as lesbian, gay, bisexual, or other sexuality, as well as people who use cocaine. Ketamine use actually peaked in the 1990s and then declined, so what we're seeing here may be a return to earlier trends. Other studies found that its approval in depression, which occurred with S-ketamine in 2019, has made people more willing to use it. Our next drug is not approved in depression, but it sure is acting like it is, with patients seeking out psilocybin therapy through underground networks or, in Oregon, perfectly legal ones. Using 5 national data sets from the United States, Carolyn Rockhill and colleagues from the federal SAMHSA and Colorado's Rocky Mountain Poison and Drug Safety programs found that more people have used psilocybin in the past year than cocaine, LSD, methamphetamine, and illegal opioids. Before 2019, use of psilocybin was relatively low and relatively stable. But in the last few years, specifically by 2023, the rate of past year use of psilocybin nearly doubled from around 1 in 100 to 1 in 50, with the largest increase among men, young adults, and people with depression, anxiety, or physical pain. Now, those numbers are for past year use of psilocybin. In 2023, 1 in 8 adults report at least one use of psilocybin in their lifetime. Now, some might argue that this is all self-medication and everyone will be a little more content and more creative on these drugs, but I'm not so sure. Ketamine causes thalamic hyperconnectivity, which is a robust biological marker for both schizophrenia and autism. Ketamine causes positive and negative symptoms of schizophrenia in healthy subjects and recreational users. That is from multiple studies in people over the last 30 years, and at least one study has used ketamine to model autism in animals. As for psilocybin, Rockhill's study is already finding problems. Between 2019 and 2023, there was a 201% rise in calls to poison centers about psilocybin exposure. That 201% rise was for adults. For children with potential psilocybin poisoning, the rise was even starker, 723%.
Have you heard the news? The FDA has dismantled the clozapine REMS program. Find out what that means for practice in our June-July issue of the Carlat Psychiatry report, where we also give a full review of the new antipsychotic Cobenfy, including new studies that look at its long-term risks and whether it can augment other antipsychotics. Get $30 off your first-year subscription with the promo code PODCAST. The Carlat report operates 100% free of industry support.